Welcome to the Health Policy Podcast, From Concept to Clinic, brought to you by the McGovern Center for Humanities and Ethics. The opinions and viewpoints expressed in this presentation are solely those of the speakers and do not necessarily reflect the official opinions or positions of the university, its schools, or departments. Any information provided is for informational purposes only and should not be construed as an endorsement. I am your host, Dr. Jessica Wise. Policies shape every step of care, from the medicines prescribed to who can practice medicine to the hospitals where care happens. Today, we'll define health, explore how health policy is made, and hear from people working at different levels within the system. Today's learning objectives are 1. To define health policy, and healthcare policy. 2. To examine policies at the local, state, and federal levels. And 3, recognize how policies are made and how they affect care delivery and outcomes. When it comes to defining health policy, and healthcare policy, what do we mean by health, and what do we mean by policy? According to the World Health Organization's 1946 framework, health is not merely the absence of disease or infirmity, but a state of complete physical, mental, and social well-being. Let's hear from a couple of our policy experts. How would you define health policy?
Health policy is authoritative kinds of directions that include decisions and plans and actions generally taken by government, but by other actors who are positioned to influence what goes on in the health sector more generally. So it includes not only healthcare and the way it's financed and delivered and regulated, but also other kinds of policies that affect people's health, like environmental quality and social conditions, and certainly public health infrastructure.
That is Dr. Stephen Linder, the professor and vice chair in the Department of Management Policy and Community Health at the UT Health School of Public Health. Coming from that nonprofit and advocacy perspective, how would you define health policy writ large?
Health policy in the global sense of health. Well, health is everything. Health is everything from what census tract you were born in, to what kind of access to fresh food and groceries do you have, anything that can impact immunization status, anything that can impact a person's sort of day-to-day health. Healthcare policy gets into the regulatory and reimbursement structures, how we pay, how we set boundaries around, for example, what can physicians do? What can advanced nurse practitioners do? Where are the delineations between the different professions in terms of what they're allowed to do in the treatment of people, and then what we pay for, which again gets very, very complicated because you've got state stuff, and you've got federal stuff, and you've got local stuff.
And that is Nora Cox, the Chief Executive Officer of the Texas eHealth Alliance. But what is the textbook definition of policy, both the health and healthcare variety? Well, from Liu Shi's Introduction to Health Policy, policy is a, quote, decision made by an authority about an action, either one to be taken or one to be prohibited, to promote or limit the occurrence of a particular circumstance in a population, end quote. Health policy, as defined by Shi, is, quote, any policy that pertains to or influences the attainment of health, end quote. Healthcare policy, which is a subset of health policy, quote, refers to that part of health policy pertaining to the financing, organization, and delivery of care, end quote. So I like to think of health policy as the legislation, regulation, rules, and rulings that pertain to or influence the attainment of health. And healthcare policy as the same thing, legislation, regulation, rules, and rulings governing, this is the different part, the financing, organization, and delivery of care. So health policy can be quite broad. From public health, there's a framework that we can use as a mental model when we are thinking about health policy and healthcare policy. So it's Donna Bedian's Structure Process Outcome, SPO model. At the healthcare provider level, the structures are the context of healthcare, facilities, equipment, personnel, organizational characteristics, payment models. And these structures have an arrow that points to processes, or they lead to processes. And these are the actions in healthcare, including those of patients and families and not just providers. And processes has an arrow to outcomes, or it leads to outcomes. And these are the effects on health status, quality of life, knowledge, behavior, satisfaction. And those outcomes can be immediate, intermediate, or long-term effects. Although Donabedian's structure process outcome model is mainly used in healthcare settings, I think it's also useful to analyze policy. So at the federal and state level, the structures would be the three branches of government. First, we've got the legislative branch. At the federal level, that's Congress, the House, and the Senate. And at the state level, you've got your state assemblies. Second, at the executive branch, it is the president, the vice president, and the executive offices, and then all of those agencies and departments that roll up under those offices at the federal level. The state level, it's the governor and all the executive offices under their lead. And third, you've got the judicial branch with the Supreme Court and all other federal courts. And then at the state, you've got their Supreme Courts and the state courts. These structures lead to processes or actions that federal and state branches undertake. The legislative bodies are passing laws and statutes. The executive branch is implementing and enforcing those laws at both federal and state levels. And the judicial branch is issuing common law and rulings on how the laws can be applied. Those processes and actions lead to outcomes or effects on health. And we can look at the immediate, intermediate, and long-term outcomes. For example, if we look at the case of health insurance policy like the ACA, immediate outcomes might be a change in access to healthcare services through coverage. Intermediate outcomes might be changes in utilization of healthcare services, incidence and prevalence of disease, and then the long-term outcomes might be changes in morbidity and mortality. Seatbelt laws are another good example. So Congress passed a law first to require cars to have seatbelts, and later states passed laws to require the use of those seatbelts. Then state laws were enforced by state and local law enforcement, and the outcome is fewer trauma-related deaths from car accidents. So in a nutshell, we've got legislative, executive, and courts that are the structure. And that structure leads to actions, so passing statutes, implementing and enforcing, issuing rulings. Those are the processes. And those lead to effects that can be measured, like incidence, prevalence, and morbidity and mortality. Those are the outcomes. Now that we have a few definitions and a mental model for thinking about health and healthcare policy, let's go back to our second learning objective, to examine examples of policies. What does policy look like in action at federal and state levels for physicians?
Clinical practice operates under policy constraints. And it's important then to be able to recognize the constraints, whether it's prior authorization for insurance or a screening that you can't order or a medication you'd like to substitute. There's policy decisions that are affecting these, some human choice that is constraining what it is you're able to do and how it is you're able to do it. My name's Stephen Linder. I'm a professor at the UT Health Houston School of Public Health. My background is in policy broadly construed. I was trained as a political scientist and have been working in policy-related fields for all of my career.
So when you think of health policy, or healthcare policy rather, that affect physicians and the delivery of care, what are the big ones that come to mind?
There's policies that affect the healthcare system itself. So how medical services are organized, financed, delivered, and accessed, insurance coverage, hospital regulation, physician licensing. And then there are the policies that affect health through a lived experience that target broader social and environmental determinants. This would include things like housing quality, food security, things I mentioned before, environmental pollution, workplace safety. The education system plays a large role, especially on the prevention side, looking at ways of educating, building health literacy on the part of people so they can do their own prevention ahead of time. And so it's Health in All Policies is an initiative that the state of California developed and has influenced legislative processes in some states looking at the impact of policies on health the way we used to do it for environmental impact, using the environmental impact laws as a model for health in all policies.
Are there any Texas-specific policies that come to mind?
Insurance coverage gaps are huge in Texas. We've got the highest uninsured rate among adults in the nation. And we chose as a state not to expand Medicaid, which meant that those that were eligible for Medicaid services would have a longer wait time and fewer places to obtain their care. Restrictive abortion laws affect reproductive health access and family planning services. Environmental and border health is big, of course, not only because in the east side of the state we've got a concentration of petrochemical firms, many of which contribute to our ozone conditions through emissions. And on the west side, we've got serious environmental problems having to do with water pollution and water accessibility and border health. Rural health is a problem in the state of Texas as well. We've got many rural areas. Problems of rural hospital funding and telehealth reimbursement and those factors affect the quality of life and our ability to prevent illness.
And now, let's also hear from a clinician's perspective.
I would like to say that I'm a policy enthusiast, but really I'm a policy expert, especially as it relates to around children and families. My name is Sandra McKay. I am a general pediatrician, and I am an associate professor and division chief for general academic pediatrics here at UT Health Houston. I have been in many different roles over the last 20 years of my career. I've been a past president of the Missouri chapter of the American Academy of Pediatrics. I've served most recently in the last 6 years as the co-chair of the Executive Legislative Committee for the Texas Pediatric Society. I also work with the American Academy of Pediatrics on their Executive Council for Injury, Violence, and Poison Prevention. I teach health policy over at the Baker Institute for Public Policy as well.
When you think of policies that affect physicians specifically in the delivery of care, like what would be the biggest one? Is it licensure or is it something else?
As a pediatrician, I think some of the biggest policies that impact physicians are ones that are related to Medicaid with payment models. Pediatricians in particular are ones that provide for a lot of patients that are on Medicaid. 70% of Texas Medicaid is currently children. Children make up a lot of Texas Medicaid, right? And that's pediatricians that are going to be taking care of a lot of those patients. So what happens with how that policy is reimbursed and how who's providing what medications are being approved on that definitely impacts us as pediatricians because we're the providers of that. So how payment models are made up can also really influence what a physician can do. Those payment models really can translate into how physicians can be effective. For example, if a physician is spending their whole day having to deal with paperwork and prior authorizations and working through insurance models and not being able to be effective on patient care, then that reduces how much I can help people. It's important to make sure that policies are strong that can reduce that overhead and that burden to physicians so that we can just do what we were trained to do in school, which is take care of people. Other things that are good examples of policies are things like electronic health records. They're ubiquitous now. We're all really used to electronic health records, being able to walk into a hospital and they're all on the computer typing away and entering all that good data. And a lot of us really like having access to our own medical records on our phone with the my charts and things. But that also now introduces a whole layer of policies that have to go with how is data shared between systems, how is data accessed by patients, how does that even get introduced with when you have young patients and teenagers, and how do teenagers now have access to their medical records? But then as a parent of teenagers, do I have access to my teenager's records? What records should I have access to of my teenager? And is my teenager now afforded some privacy with their physician? Policy does now have to play in so that way we can make sure that we're providing a safe environment for children and for young adults, but then also promoting high quality healthcare too.
Outside of the healthcare system that you just described, are there any other social and economic determinants, so health policy writ large, that you think really impact the lived experiences of populations? So for example, in Texas, maybe specifically kids in Texas.
Another area that we don't tend to think about as much in Houston, but I think that we need to think about in Texas, is rural care access. Part of my previous role when I lived in the Midwest was I took care of a lot of patients that were living rural. And that is a hard area to provide care for. And I think when you think of poverty, and it's a completely different way to address poverty when you're caring for people in urban settings versus rural settings. Because in urban settings, there's some infrastructure, where you can have people at least have access to some sort of public transportation, some sort of means of transportation. There are some centers that can get to people if they can't get out of their homes or their places. In rural areas, there is no Wi-Fi. There's no fiber optic cable that's ever going to be dropped to your place. It is very challenging for people to get to places. They may have to drive 2-3 hours to get to a physician. There may not be a specialist for hours. And when you're the only general pediatrician in a 300-mile radius, and then your specialist is a 5-hour drive, that's really scary for a lot of families. And so I think access to care, especially in our rural areas, and much of Texas is rural. I think that we don't think about that a lot, especially when you're living in Houston, which is the 4th largest city in America. Texas has a lot of big cities, but we also have a lot of rural areas. And so it's really hard as a state to balance the challenges of, big city living with a lot of deep rural areas and hard to reach areas.
Thanks to our policy experts, we've heard about a lot of policies that affect health and healthcare. So we've got CMS, the Center for Medicare and Medicaid Services, the ACA, the Affordable Care Act, and MACRA, as policies that affect payment systems and healthcare coverage, health insurance coverage. And then we also heard about HIPAA and HITECH, and these are policies that affect privacy and patient records. Then we've also got things like EMTALA, FDA approvals, reproductive health laws that affect what treatments are available to patients. And just like California's health and all policies, there are many social and economic policies that can affect health downstream. And these are just to name a few of the policies that can affect health and healthcare. So coming back to our third learning objective, how are policies made and how do they affect care delivery and outcomes? Is there anything that you think is critically important for our med students as future physicians to know about health policy?
I think, first of all, that policy affects them in many different ways. It affects their practice. It affects who they can reach in the population. And so it's of utmost importance to pay attention to policy, especially those that are relevant to health and public health. And so I know a lot of physicians in training probably took a lot of science background courses and civics or political science. I know when I took it, I actually took advanced placement and didn't even take the class. And then later, trying to catch up and figuring out the difference between federal policy and who your federal representatives are, and state policy and who your state representatives are. So it's very critical for physicians to be in the know about health policy, and then what are the levers that they can employ.
And that is another one of our policy experts.
I'm Deanna Helsher. I am Regional Campus Dean for the Austin campus of the UT Health Houston School of Public Health. I'm also Director of the Michael and Susan Dell Center for Healthy Living, and I am the John P. McGovern Professor in Health Promotion.
Let's also hear from Dr. Linder, our policy professor, on the role of law and politics in this policymaking process. How do politics and the law come into play for health policy?
Different institutions affect the policy process. And one set of institutions are on the lawmaking, law interpreting, law implementing side. And generally, those institutions try and steer clear of actually generating the laws themselves and are influenced by politics. Politics is generally the raw materials that law is made up of, and it's the priority setting through the political process that determines the direction law takes and the way law is implemented. So even though policy change appears to happen very quickly, and it can in certain areas, most policy is made through a developmental process, and it goes through various stages of development. And it starts with initial formulation, and you find a place on the public agenda of elected officials who begin to prioritize certain areas for investigation. The formulation then follows some investigations that are done in the federal case through Congress, in the state case through our elected assemblies, state and Senate and House. And those investigations provide an opportunity to take public testimony, to take expert testimony when necessary, and begin the formulation of the bills themselves that'll form the basis for debate and eventual enactment. Once the bills are formed into statutes and having been enacted and legitimized, they then go to the agencies that are delegated authority to implement them. And the implementation then is a long, sometimes fraught process because the process is generally one that goes back and forth between the elicitation of stakeholder input to ensure that feasibility constraints are met, but also the possibility of other voices being brought to bear. And then finally, when the laws themselves and their implementation are challenged in court, you have another opportunity then in that cycle to intervene.
Dr. Linder is describing the policymaking process. And if we think about it as a feedback loop or a circle or a clock, you've got agenda setting at the top at the 12, and then you've got formulation at the 2 o'clock, adoption at the 4 o'clock, implementation at the 6, assessment at the 8, and adaptation at the 10, and then it repeats. The cycle repeats. You're back at the top with agenda setting. So agenda setting is the pressure to address a particular problem. Formulation is where officials come up with alternative policies to address the problem. Adoption is when the policy is officially put into place, like when a bill becomes statute, or there's a court decision, or agency director consensus. Implementation is when the policy is carried out by administrative units, and that's hopefully with funding and resources. Assessment is the auditing and accounting to see if there is compliance and to see if it's achieving the goals of the policy. Adaptation is when changes are made. So they determine if a policy is no longer needed or if it needs new objectives, if the policy problem has been successfully addressed. And the influence goes clockwise, but it can also go counterclockwise, and implementation and adaptation have a two-way arrow going back and forth to each other.
So you can see the developmental process, the stages that policy goes through as a series of leverage points. And at each of those points, you're able to exercise voice and have some expert input into the overall process. And so there's at least a dozen different opportunities across the span of policy development where you can have a say and make a difference.
Let's hear from another one of our policy experts, this time from the nonprofit sector. How does your organization come in and influence health policy at the state and federal levels? What levers are you pulling?
All of the levers. Any lever I can reach. No, I'm just kidding. Nora Cox, I'm the CEO of the Texas eHealth Alliance. We are a 501c6 trade association. What that means is that we represent companies and stakeholders that are competitors in the healthcare market, but have come together around common causes, things they want to fight for, things they want to work for. I am a longtime health policy nerd at the Capitol. I'm in my 31st year of doing legislative work. My resume includes working for the Texas Medical Association, the State Office of Rural Health, the Medicaid program itself, 5 years in the governor's office overseeing the Health and Human Services system, and then I've been in this job for 16 years. So this job is great because it lets me be an advocate for the use of technology to improve the healthcare system for patients. That's literally our mission statement. And I've gotten to live the evolution of technology from it's that thing that lives down the hall that certain people work on, doesn't impact the rest of us, to kind of a way of life.
And so I asked Nora Cox to share what the policymaking process looks like when it comes to those e-health policies that her organization works on.
It gets very, very complicated because you've got state stuff and you've got federal stuff and you've got local stuff, and it can be hard sometimes to distinguish where the levers actually are to create the change. Sometimes an issue will kind of surface in the public realm. We're having this problem, this thing is broken, this thing is not working, or there's a new federal program, how do we interact with it? So sometimes we are responding to bigger forces that are out there. The federal government has done something and Texas doesn't like it, and frequently does the opposite because that's sort of what we do. So there's a component of advocacy that is reactive. But the other thing that we do that I think is really makes us different from a lot of other organizations is we have an advisory council made up of our providers. And so we go to them with issues and we say, hey, this seems broken. Is it broken? Or is it working badly because the people who built it wanted it to be working badly? I think a lot of people would say that, for example, about prior authorization in insurance, right? We've gotten to the point where, that feels like that might be the advent of AI taking over the world. It's going to be through the provider AI fighting the health plan AI over prior auth. What we like to do, though, is have conversations with groups that represent providers and with groups that represent patients and say, tell me where your pain points are. Tell me where there is abrasion in the system that you are feeling and seeing. Where are we missing opportunities? And I'll give you an example of that sort of work. A couple cycles ago, I was asked by a legislative office to look at how we do remote patient monitoring in Medicaid. So this is a benefit that we have that I've worked with for a long time. It was poorly designed in the early years. It was kind of clumsy. We weren't really getting the maximum benefit to the state. And so I started looking at what did all the other states do during COVID? Like, are there things that Texas could be doing that we're not doing? And I found in Illinois, during COVID, they had done remote patient monitoring for high-risk Medicaid pregnancies. And I thought, well, keeping babies out of the NICU seems like a really good idea. So I got more information. I wrote it up. I socialized it with my team. I said, hey, I think we should look into this. They said yes. I went to my key legislative offices and said, hey, I think we should be doing this. And they all said, we're not doing that. This is the answer I get a lot. What do you mean we're not already doing the thing? No, we're not doing the thing. So I will tell you that in 2023, we got the Texas legislature to agree to have Medicaid reimburse for remote patient monitoring, so monitoring at home of high-risk Medicaid pregnancies. And I kept waiting for something to go wrong, just because it felt almost too easy. Like everybody was like, what do you mean we're not doing that? That's a thing, we should do the thing. So we passed it. We're working through implementation with our state agency right now with Health and Human Services. It will come online later this year because high-risk pregnancy is a very high-risk topic. It's very sensitive. They wanted to go slow with the implementation, which was fine. We have to get federal approval. We have to do all these different things. The technology is changing at a pretty rapid pace. But by the end of this year, we're going to have this in place, and providers like our federally qualified health centers are going to be able to monitor pregnant moms at home and get paid for it. So those are the sorts of things that we look for. Where are the gaps? Where are the opportunities? That's our initiative. That's my responsibility as the head of the organization, to kind of constantly be scanning for opportunity to bring new ideas to the Texas legislature. Sometimes they call me, sometimes I call them, and sometimes our membership brings us things that need addressing, and then we use our coalition to work the process to get those problems solved.
The policy making cycle is really like a circle. It repeats over on itself.
100%.
And so I heard you talking about some agenda setting, some formulation if we're thinking about that policymaking framework, the adoption of the law. It was written into statute, this policy for remote monitoring high-risk pregnancies. And now you're in that implementation phase, but it's, the law was 2023 when you were doing this work, and now it's 2026. So again, it's taking time to go through the process and then ultimately see those better outcomes for mothers and babies that are using Medicaid.
That's what we're hoping. I mean, if I only keep one baby out of the NICU a year, that's one baby not in a NICU. I'm a winner at that point. But policymakers, leadership, they want it quantified. They want to know. High-risk pregnancies do have to be handled with care, literally and figuratively. And so I'd rather get the policy right, move forward with everybody feeling good and comfortable about what kind of technologies are going to be best, how is that information going to be conveyed to the provider, and how are we going to measure success?
Speaking of success, I also asked Nora Cox about Donna Bedian's structure, process, outcome model, and what structures, processes, and outcomes were really relevant when it comes to these e-health and e-technology projects that she's working on.
So health, e-health, we talk about e-health, we're talking about the big picture, and then you get into health care, then you're talking about sort of how do you use health tech in health care. And I think those distinctions sort of help us figure out which lanes belong to us as technology vendors, because that's what my organization represents in the marketplace. And we have to follow federal antitrust rules. So we are not out there advocating for any company's specific technology. We really do have to look at what are the ways we can make an impact, maybe by improving reimbursement for a certain technology that Texas Medicaid is not paying for. And we have done that several times, and we can see the results of that because the government is tracking the use of that technology and the impact on patients. So health is, I think, harder to measure. I would also say sometimes the big picture of health. Healthcare, though, we tend to count widgets and not outcomes. So I spend a lot of time in conversations about how do we pull those things together, and then how do we move towards a system that actually looks at outcomes, which everyone says they want, but it is really, really hard to get there.
So we have got Texas Medicaid as the structure, reimbursement procedures as the process, and then telehealth use as an intermediate outcome, and maternal and infant morbidity and mortality as the long-term outcome in this case. Now that we've heard about the policymaking process and Donna Bedian's structure, process, outcome model from a nonprofit perspective, let's go back to academia and see what the researchers have to say about this policymaking process.
I am Shelby Flotis-Thorpe. I am a postdoctoral fellow at our Austin campus for UT Health School of Public Health. I work under Dr. Helscher at our Austin campus location for the Michael and Susan Dell Center for Healthy Living. Dr. Helscher and I run a project called the Texas Research to Policy Collaboration Project. And so we work with our state legislators really to educate them on public health and child health in general.
And I wanted to ask, how does your organization do that? Like, what does that look like day to day, that educational component that you're providing?
So we like to get our legislative friends and colleagues, as I like to call them, data and information. In a lot of the resources that we provide, we try to give them actionable, smaller steps that can be taken to work into policy if they so choose, or at least to just consider when talking about policy. We go to legislative offices. It is an opt-in to our project, but if they do opt in, we will go in and conduct our policy identification needs assessments. So we call them PINAs. We ask them about what they're interested in filing in for the legislative session, but what we think they are likely to file. So these can be different, but then they will also base a lot of the work that they have to do off of the interim charges that will come up, and that usually comes in the even numbered years. So we're waiting for the interim charges probably later this summer from both the House and the Senate on the state level.
And here's Dr. Helsher again, weighing in on those day-to-day activities.
And I'd like to bring up a few, kind of highlight a few points. Is number one, we try and meet the legislators where they're at. So if there's certain issues, as Shelby mentioned, that they point out, those are the ones we kind of tackle first and see if we can get expertise. And a lot of times what we find is it works as a partnership, that once you've addressed an issue that they want, they'll come back to us and say, you know, do y'all have other suggestions for us? Are there other things that we can do? And there might be things that are issues that we have specific briefs on that we can hand to them and make suggestions. We can educate them on what other states have done, and we do it through this partnership method.
It sounds like a lot of the work that you do happens in that off year, so when they're actually not in session. So for the folks that don't know what interim charges are, can you explain what that means a little bit more?
The interim charges are just topics that the House and the Senate, so it will be the Lieutenant Governor for the Senate and the House Speaker for the House, will come up with and say, these are topics that we are interested in for 2027.
And Dr. Helsher, do you have a little bit more to add?
I think another thing that's kind of unique about Texas is in that interim time. I know a lot of people just think it's the legislative session and then that's it. But you can nurture these relationships with legislators in this interim time. You also can kind of have nice conversations with them that are more relaxed than when it's the legislative session it's so busy. They have so many pieces of legislation, almost 10,000 that they have to comb through.
Can you share anything that you are working on during this year in preparation for the 90th legislative session?
A few of the things that we're really interested in. So I was on the Dietary Guidelines Advisory Committee, so got kind of a peek into it, especially when you look at food as medicine. For example, there was Texas House Bill 26. This bill set up a pilot program for high-risk pregnant women with chronic conditions. So it's only a pilot program at this stage, but what we would like to see in the next legislative session is to provide some data on how could this be expanded, what would it take, what are the current outcomes that we've seen with it, and then look at, can that in lieu of services be used for something like purchasing food for like a culinary medicine course? Because right now the legislation doesn't cover food, and especially in high need communities, if you're asking them to cook different types of food or fruits and vegetables which are perishable, it can be difficult for them to include it in their budget.
Coming back to our learning objective on how to recognize how policies are made, if we're thinking about our policy process clock, Dr. Helsher and Dr. Flores Thorpe, as experts, are providing their expertise and knowledge in multiple steps of the policymaking process. They are providing input for the agenda setting and problem identification at the 12, and for the formulation of alternative policies at the 2. They are also providing data and analyses for implementation, assessment, and adaptation at the 6, 8, and 10, as a policy is piloted and then scaled up in the example that they were just discussing. And now you might be wondering, how can a physician bring their expertise to that process?
It's very critical for physicians to be in the know about health policy, and then what are the levers that they can employ.
I imagine that an obstetrician might benefit from knowing about a pilot program like the Food is Medicine. So definitely policies that are specific to their practice as well. Here's our policy professor, Dr. Linder, one more time.
I think that a lot of your clinical practice operates under policy constraints. And it's important then to be able to recognize the constraints, whether it's prior authorization for insurance or a screening that you can't order or a medication you'd like to substitute. There's policy decisions that are affecting these, some human choice that is constraining what it is you're able to do and how it is you're able to do it. Understanding the parameters that have been fixed in that regard is useful to you, because that's the first step to being able to make change and being able to expand your degrees of freedom outward once you begin to focus on who is setting these parameters and how they're being set, constraining the nature of your practice. I think physicians have a credibility. It's lasted beyond the COVID epidemic that gives you certain moral authority. And because of that moral authority, it gives you certain power to speak on health matters. And that credibility comes through as leverage potentially over the process. You can help people understand, help elected officials understand what the health implications of what it is they're doing happen to be, and what needs to be done to further protect people's health.
Now that we've heard about the policymaking process and some of those levers that can be pulled with expert and physician knowledge, let's hear about a couple of case studies, one from a clinician's perspective and another from that nonprofit perspective. Let's talk to Sandra McKay again, our pediatrician policy enthusiast and expert. Can you share an example of how your input as a physician has shaped a policy? I've got one example I know of. I received a letter from HISD that was partnered with Houston Police Department about safe gun storage. And it was an acknowledgement for me as a mom, as a family, that we had safe gun storage in our home. And I know that that might be something that you've worked with in the past.
That's a great example. We worked on, that was actually a whole coalition here in the state of Texas that we've been working on to try to promote secure firearm storage education in any way that we could. And it's a challenge to, see how we can improve education around secure firearm storage in the state of Texas. And it's about, having good conversations with legislators about saying, we're not here to take away anybody's firearms. I mean, I've got firearms at home, and that's not our goal. And I'm a firearm injury prevention researcher. And our goal is how do we get information out to people to say, hey, you've got kids at home. You obviously do. You have children in school. So how do we remind you that, sometimes we can get lulled into a sense of complacency, and this should be a priority item for you. And we want to make sure that everyone gets the same message, which is if you have kids at home, those firearms need to be stored securely. And that's your responsibility as a parent. That's it. And that's a message that everybody gets on board with, regardless of what your political affiliation is. We worked collaboratively as a coalition, as a team of multiple stakeholders. It was not just gun violence, advocates who may lean a different way, but we had gun retailers, we had gun owners, we really worked collectively to make sure that we had multiple voices at the table, credible voices too. And I think that's something that's really important is when you're looking at shaping policy, that you are bringing multiple voices to the table. I can bring my perspective in as a researcher and as a physician and as a parent and as a gun owner, but I can't speak to how gun retailers are going to do that. So we made sure we brought their voices to the table too. And it's about being collaborative.
What point in the policy development process was that? When you were getting multiple pieces of input from stakeholders, was it like an implementation or adoption?
You have to bring your key stakeholders early on in the process, especially when we were having the bill crafted and when we were essentially in the interim, when we were crafting the bill and working with our key legislators. We wanted to make sure that people knew what our goals were. And this was specific to this bill because we knew that it might face some opposition because of the type of bill it was. And I think when you're looking at policy, you have to know the landscape of the policy that you are investigating and hoping to aim to pass, right? And you have to know what is the appetite for that bill, right? Is it likely to pass? Is it not likely to pass? Could it face some opposition? And then you have to go in strategically as well. And you have to understand, who are my proponents? Who are going to be my opponent? What are my strategies going to be to address the concerns of the opponents? And that was certainly some of the things that we did immediately at the very beginning of this. Sometimes you might want to be the person to be talking in the room, but you are not the right person to be talking in the room, and you have to take a backseat to somebody else. So that way you can allow their voice to be heard because their voice is the more trusted messengers.
What were the outcomes of this effort to get the Texas state law changed?
Ultimately, we were successful. As a result, we were able to get this passed, get the safety legislation into law, and then schools had to adopt it. And so then what this then ended up being is then you have to follow the implementation side and see our schools actually doing it, right? And so that was then turned over to the Texas School Safety Center. And so they're the ones that also follow the things like the youth behavioral risk assessment. So they do lots of different risk assessments, and they followed other things around youth violence and were really formed more after like the Santa Fe shooting as well. And so they have a lot of expertise in this field. And so they're following and tracking which schools have done it, which schools haven't done it. And I think some of the research that will be coming out of this will be, are parents looking at it? We don't know. We don't know if it's just going out in a mass newsletter or is going home in a folder. How are schools actually implementing this? And does it make a difference? Does it make a change? Are people we're responsive to this? We haven't heard anything negative from firearm owners, which is a positive in my mind that people aren't complaining about it. So that's good. But then we have to look at, is it actually making behavior change? In the firearm research world, that's kind of like the golden egg right there is what's going to make people store their firearms securely? And then ultimately, what is going to reduce firearm death? And that's kind of a longer game. Our approach is anything that we can do to start moving that needle down towards reducing death. More is to come because this is new legislation. We're just going to continue to monitor how implementation goes and how schools are implementing it, and to see the impacts of it moving down.
So I see the outcomes kind of like spanning immediate, intermediate, and then long-term effects. So immediate is that the law passed. Maybe intermediate is how many schools are implementing it one way versus another. So how many schools have done it? How many letters have gone out to families? What does that look like? And then maybe long-term is reduction in risky behaviors related to firearms, and then also reduction in firearm deaths and injuries, and an increase in safe gun storage. Is there anything that we haven't covered that you think is really critically important for medical students to know about health policy?
Take the time to make sure that you are educated. Make sure that you stay abreast on how the policy is evolving, because sometimes policy moves fast. And make sure that you use credible sources when you're looking at policy. So TikTok is not a credible source. I would not rely on that. And certainly you can rely on your professional societies. They are great resources for you. You don't have to go it alone. And also your government relations teams at your institutions are also great resources to provide you with credible information as well. So you have a team around you willing to support you if you're interested.
And here is Nora Cox again on e-technology. Would you like to tell us about any of the Texas eHealth Alliance priorities that you had from this past 89th Texas legislative session?
So there's one that I think you may have already heard about that I love to talk about because it's such an amazing opportunity to make improvements in the healthcare system. I guess it's been almost 2 years ago now. I was approached by some stakeholders, our State Health Information Exchange, the Texas Health Services Authority, and some of our hospitals. And they told me something I did not know, which happens frequently. Even with 30 years in the business, I'm always learning something. And that was that if you are treated at a hospital and then you pass away outside the walls of that hospital, it is on your family to tell the hospital that you have passed away. There is no mechanism to inform a treating hospital. So, for example, let's say you have a knee surgery and you live on the other side of town, and unfortunately, on your drive home from your surgery, you're in an auto accident and you pass away at the scene of the accident. Literally, no one tells the hospital. So what happens is grieving families are getting phone calls and letters and medication and follow-up from the treating hospital. And they're grieving. They're trying to plan a funeral. They're trying to deal with a whole bunch of things. We think that as many as 25% of the people in hospital electronic records are actually deceased and marked alive, because 60% of patient deaths occur outside the hospital. So there's a study out of California I can send you that kind of looked at this. So I had no idea. I assumed the state health department was telling somebody about this. Well, they don't really do that. And the reason for that is we have a lot of protection against identity fraud built in around birth records and death records. And that makes a lot of sense. But a couple of cycles ago, we changed the law to give the list of the people who have passed away to the Driver's License Bureau and the Secretary of State's office to help them keep their rolls current. And so we thought, well, why can't we do the same thing for hospitals? Why can't our level 1 trauma facilities get the list, and then they can use it to double check, make sure, but also take people out of the record that are no longer alive. This also speaks to value-based purchasing and paying for outcomes. How do you measure the efficacy of a program if you don't know if the patients in the record that you're analyzing are alive or dead? And there's a real human cost to this. And one of the examples I'd like to use comes from Parkland Hospital in Dallas. They have a suicide prevention unit off their emergency room. They don't know if it works, because unless the patient comes back to Parkland, they may never have contact with them again. And so it creates a lot of uncertainty around efficacy, creates a lot of manual work trying to track people down. You're talking about facilities that treat a lot of people who are undomiciled, they're transitory, they may have a cell phone, they may not have a cell phone, we don't really know. So it's hard. So there's an administrative piece, and then there's a burden on the families that seems to me to be quite unnecessary. Why should it be on them to call all the providers? I will also say, and I say this publicly, so I'm not telling secrets here, I am a breast cancer patient. I'm doing very well. I asked my oncology practice what they do, and they said, oh, Nora, we read the obituaries. That's how we know if our patients have died. That is unacceptable. That is unacceptable. So we met with the health department, we built a coalition, we figured out what part of the law to change. We got a Democrat to file it in the Senate, we got a Republican to pick it up in the House. This bill passed with no opposition, not a single vote against it in a committee, on the floor. We got a little bit of money, an extra employee for the health department. Everyone I talked to, Dr. Weiss, everyone I talked to had a story. This happened when my mom died. The clinic wouldn't stop calling. This happened when my aunt died. The hospice was calling. How's she doing? Well, she died 2 days ago. And the family, it didn't occur to them to call the hospice provider and tell them she was on hospice at home. Everybody had a story. So we serve as sort of I like to think of myself as an orchestra conductor. I know when to get the woodwinds to play and when to get the percussion to play and how to get everybody to sort of present in harmony, because what legislators want to know is this agreed to? Who's going to be mad if I vote for your bill? Who's going to come in and be upset with me if I take your side? So we were really able to get everybody on board, rowing in the same direction for this. And it's taking a little time to figure out sort of the technical details of how we pass the data. Does something come to the health department first and then they send something back to the hospital, or how? We've got some technology challenges we got to work out. But in the big picture sense, it's just an unacceptable situation that we backed ourselves into. And there are human costs. So there's administrative costs and costs to the system, but there are human costs here. And it's a storytelling business. We talk about data all the time. We should be data-driven. We should be data-driven. We should be data-driven. But a good story that is true and accurate and strikes as true, when I have less than 2 minutes to convince a legislator to take my side on something. Maybe 3 minutes if I've got a staff member, maybe. And so this one was really pretty easy. Did you know this is happening? Either no, why do we do that? Or yes, oh my gosh, it happened in my family. And both of those were yeses in terms of getting support for the bill. So that's an example of something that was driven up from our provider members and from the stakeholders. And they brought it to me because my skill set is the coalition building, the storytelling, covering the bases, doing the persuasion, and giving the legislators a comfort level that you can vote for this because it does something really good. And in a time where we're very partisan and politically polarized, and there's lots of sensitivity around lots of things, we called this the little bill that could. We just kept chugging along through the process. We kept waiting for something to go wrong. And instead what we found was people were glad that someone was finally solving the problem. So that's a story of when everything lines up properly, and it's not always that easy. It's not. But this one is going to make, just like the RPM for high-risk Medicaid moms, these are things that are going to make a difference for people. And that's why I'm in this business.
Coming full circle, what have we learned today? First, healthcare policy frames how care is delivered. Second, health policy impacts the lived experiences of patients. And third, we learned about 2 frameworks to think about how policy impacts practice. First, on a median structure process outcome model, and second, the policy-making process model. And finally, we learned that physicians have a voice in shaping policy. I asked each of our policy experts the same final question. So if you could sum it up in just one sentence, what is your best advice to young doctors coming into the current policy landscape?
My suggestion is don't be afraid of policymakers.
Just reiterating that you need to know about policy. And so some handy resources that you might want to go to is the Texas Legislature Online, TLO, follows legislation. And it's really nice because they even have check marks about whether something passes or not during the legislative session. And it's capital.texas.gov. So you can go to that and follow legislation. Also, if you can go to our Michael and Susan Dell Center for Healthy Living website and look at Texas Research to Policy Collaboration Project, there's a lot of resources there for any physician interested in starting out in this policy journey.
Stay grounded in evidence and your duty to patients, but you want to build some political and communication skills so that you can navigate a really polarized environment where science expertise is contested. The most effective physicians, I think, will be those who can translate the medical realities that they face into some insight that'll resonate across both sides of the aisle across the ideological divides without compromising your integrity or the knowledge that gives you that moral authority.
Use your voice and don't be afraid.
And you have to be really resilient, because you might think you know, and then you start working on something and you find out that you knew nothing. So then you just pick yourself up and you sort of move on to the next project. I love health policy. I love working in it. I consider myself really lucky that I get to do this every day.
Medicine doesn't stop at the clinic door. Rather, policy is a part of the practice of healing. Thanks for listening.